So we are stitching a program to address the knowledge gaps which we identified in our survey.
Right.
So I will pass it on to you once you finalize that. And so it's
the same thing which we discussed
survey.
with the subsection meeting, no?
Yes, which we presented there.
Okay.
So those issues will be discussed.
Yes. I think we have to discuss about the meeting a little more also.
Sir, I open the room. You can start.
Okay.
Yeah, I will be starting soon. Just a couple of minutes.
So again, this program journal club either should be on Friday or Thursday, because AIMS Delhi also has a problem with Monday meetings, as I suggested in the group. But we have to shift it to either Friday or Thursday.
Yes. So let us see.
Most of the big institutes have heavy OPDs on Mondays. They're not able to complete.
Yes, Monday is I think for everyone, Monday is a very long day, sir.
Yes, Mondays are usually long days. It's first day after the week starts.
That's why I was requesting our chairperson to consider changing it.
I think Saturdays IAN has a lot of other meetings. So
yes, Saturday
Friday
nobody will attend, sir.
I think
Saturday nobody will attend.
Yeah, we can actually fix it on Friday. It's fine with me. Yes.
Dr. Prasad has any comments about the Friday meetings?
Yes. Friday, yeah, why not? You go ahead, but Friday, whenever Saturday, Sundays are holidays, I go from Ranchi to Delhi on Friday evening. So that is the problem. But
Thursday we can think, Dr. Sunil, we can think on Thursday also.
Thursdays, we could even almost we can forget, because they're in the middle of so many things in the middle of the week. So by towards the...
Otherwise, we'll miss Dr. Prasad's comments. No, we want him.
No. It will be only when it will be alternate. Second and fourth Saturday is holiday here. So I usually do this only on end of second week and end of fourth week.
So ours is first week, sir. First Friday.
First Friday.
Sir,
Yes, first Friday is okay. First Friday is okay.
But this time we could not do because of some reason. We had to postpone it. Otherwise, it's always first week.
Then there is no problem.
Yeah, I think people are still trickling in. Another minute, 1 minute or something, you'll start. Your presenter has joined, no, Dr. Shailaja?
Yeah, Dr. Krishnamohan is here.
Yes.
And I think it's a very important topic as far as acute stroke management is concerned. And Dr. Sunil, you can start your comments and we can start.
Yes. So, good evening all. I think we are slightly deviating from the regular Monday schedule to an experiment of Friday this month. And already we are, I think the participants are keeping on joining. So I'm sure you are going to have a good audience and participants this week. So let us see how it goes. Coming to the today's discussion, I thank Dr. Shailaja and her team, Dr. Mohan, for volunteering to do the presentation today. And thank Dr. Kamesha Prasad, who is I would say, the founding chairman of these activities which we have started, the subsection programs, has also kindly joined as an expert commenter for today's journal section. And of course, Dr. Goti, my colleague and convener, for making sure that the digital team makes all communications sent out in time. And this particular topic, I think, especially being presented from Sri Chitra, who do have, I believe, a lot of experience in use of oral anticoagulations and especially novel oral anticoagulations in view of a very good cardiovascular department also. I think a very important topic. More and more people have started shifting from warfarin into the novel drugs because of the lesser side effects profile and a short duration of action, so better control of any adverse events. So, but at the same time, the thrombolysis has also significantly increased all over the world. So, how safe and to thrombolize in patients who are already on oral anticoagulants is a burning question. So, this paper addresses this very important question and regarding the paper and its methodologies. And I request Dr. Shailaja to now specifically introduce the paper and then to start the proceedings.
Thank you. Thank you, Dr. Sunil. First of all, I would like to thank Dr. Sunil and Dr. Goti and the IAN team and Dr. Prasad sir for giving me this opportunity to, and my Sri Chitra team, to be part of this journal club today. We have a very important and very most relevant question which is being answered in this article which we are presenting. And I have with me Dr. Krishna Mohan, who is a final year resident in neurology, and Dr. Krishna Mohan will be presenting the paper. Today, as we all know, DOAC is that's a direct oral anticoagulant drugs are the drug of choice in patients with non-valvular AF. And we tend to, because now we have got less costly, the cost has also come down. We tend to use it more, and we are likely to see more patients with acute ischemic stroke who are already on a DOAC. One of the most important limitation, or one of the most important fear of giving intravenous thrombolysis to these patients is because of the bleed risk. If you look at all the current data, just like how warfarin has evolved, we know that if the patient has taken the drug, if it is more than 48 hours since the ingestion of the drug, or if you have the facility for looking at the thrombin time or the drug assay, these are the situations where you tend to give the drug. And most of the time, if you have a facility for mechanical thrombectomy, you tend to take these patients for direct thrombectomy. But one of the important questions which has been answered, or which is being answered in this important article, is with regard to whether giving intravenous thrombolysis is safe in patients who have had the DOAC injection within the first 48 hours. Because the main reason is we need to know this better, because compared to warfarin, we know that the bleed risk with DOAC is significantly low. So it is really worthwhile with the above. And if you look at all the data available, is that all are small series, where some of the series have looked at the drug assay and treated these patients, or when the patients have taken the drug more than 48 hours. So we do not have a real data to go by, and the chances of having a randomized controlled trial in this kind of a question is going to be not possible most of the time. So this important paper with such a large sample size is going to answer this question, so that how safe we are in giving the intravenous thrombolysis in patients within 48 hours of having the stroke if they had the ingestion of the drug. I would like to invite Dr. Krishna Mohan to have his presentation, and then we will have the discussion. Thank you.
Good evening, respected faculty. I am Dr. Krishna Mohan. Am I audible, madam?
Yes, you are loud and clear. You
yes,
can see
yes.
the slides also.
I am Dr. Krishna Mohan, final year neurology resident in Sri Chitra Tirunal Institute of Medical Sciences. First of all, I would like to thank IAN stroke subsection for giving me this opportunity. I would also like to thank my professor and head of the department, Dr. Sailja PN, for giving me this opportunity. So coming to the introduction, as already the senior professors have told, that the increasing use of DOACs has led to the question that whether IV thrombolysis in these patients is safe or not. The direct oral anticoagulants includes both direct thrombin inhibitors and factor Xa inhibitors, and these agents are have been widely used for the primary stroke prevention in non-valvular AF. Also, there are newer indications coming up for these drugs, which include venous thrombosis, pulmonary embolism, stable coronary heart disease, and peripheral artery disease. So, with increasing indications and people using this widely because of the better side effect profile, we are likely to see more patients with acute stroke while on direct oral anticoagulants. And the question arises whether these patients are, should we do IV thrombolysis for these patients or not? So this table shows the four important direct oral anticoagulants: dabigatran, which is a factor Xa inhibitor, and rivaroxaban, apixaban, and edoxaban are factor Xa inhibitors. And it also highlights the important difference between these drugs. And we can see that dabigatran is having the highest renal clearance, and apixaban has the least renal clearance. Unlike the vitamin K antagonist conventional drugs, these drugs cannot, the therapeutic efficacy or the therapeutic levels of these medicines cannot be assessed by the routine prothrombin time and activated APTT. So for the dabigatran, we need to measure thrombin time because it's a factor, it's a thrombin inhibitor, direct thrombin inhibitor, and the presence of normal thrombin time excludes any dabigatran, circulating dabigatran in the patient. And for the rivaroxaban, there is no test other than the assessing the anti-10A levels. But in all these patients taking the factor 10A inhibitors, usually the INR is elevated. So they have suggested to use dilute thrombin time or recurrent basic clotting assays in patients on dabigatran, and in patients on factor 10A inhibitors to do the calibrated anti-10A assays.
Budding शुरू हो गई है तो चलना ठीक है.
And for the reversal agents being approved, idarucizumab has been approved as a reversal agent for emergency purposes in patients on dabigatran. But for the androstenedione alpha, which has been approved for factor 10A inhibitors, is not approved for the urgent interventions.
Dr. Krishnamohan, just wait one second. Dr. Prasad sir, you want to go? You want to say something and go?
अगर बहुत लंबी अगली है तो रुक जाओ, ऐसे हड़बड़.
Right, sir. Then we'll continue. Okay, Krishnamohan, please continue.
So, what does the guidelines say regarding the situation? The 2019 update of American Heart Association guidelines says that the IV thrombolysis in patients on DOACs may be harmful. A similar guideline has been given by the European Stroke Association, where they recommended that not to thrombolyze in patients who have taken the newer oral anticoagulant less than 48 hours ago, unless they have the calibrated anti-10A activity or the factor 10A levels or the thrombin time for patients on dabigatran or the blood concentration of these drugs. And they suggested not to do IV thrombolysis. And though the level of evidence is low, they have given a strong recommendation for this. So these guidelines were based on the presumption that increased risk of symptomatic ICH may be seen in these patients after IV thrombolysis while on direct oral anticoagulants. But there is no data to support or refute this presumption. And we cannot extrapolate the data from the vitamin K antagonists to the DOACs because we know that the risk of symptomatic hemorrhage in these patients while on DOAC is less compared to the vitamin K antagonists. So there are few observational studies being done regarding the same. Here, this study, which has been published in Stroke Journal in 2020, shows that they have included 13 patients who were on dabigatran, received tenecteplase for IV thrombolysis when they had acute ischemic stroke, and all of them had atrial fibrillation as the indication for the dabigatran therapy. And they found out that no patients had parenchymal hemorrhage or symptomatic hemorrhagic transformation. And they found a favorable functional outcome in 62% of the patients. And they suggested intravenous thrombolysis with tenecteplase following dabigatran reversal may be safe in acute ischemic stroke. Another study from New Zealand, which they included patients between 2017 and 2018, published in Neurology in 2020. Here they included 51 patients who received idarucizumab prior to thrombolysis. And they found out that the symptomatic intracerebral hemorrhage occurred in 3.9% of the patients who are being treated with idarucizumab and 3.8% of the patients who did not receive, who were not on DOAC and did not receive idarucimab. And they recommended, and they told that idarucimab appeared to be safe with similar clinical outcomes to routinely managed patients. Only there was a 22-minute door-to-needle time delay, but still the functional outcomes were comparable in both the groups. And this meta-analysis, the systematic review published in Frontiers of Neurology, they have included 251 acute ischemic stroke patients, and they have looked at the rates of hemorrhagic transformation, symptomatic ICH, and death. And they found out 7.6% of the patients had hemorrhagic transformation, and 3.6% patients had symptomatic intracranial hemorrhage after IV thrombolysis with after the reversal with idarucimab in patients receiving dabigatran. And they found out that after IV thrombolysis in these patients, there is significant NIHS reduction of 6 points, which is statistically significant. Here, this table shows all the observational studies, which included the patients receiving IV thrombolysis while on direct oral anticoagulants. And they have divided the patients into 3 groups. One is the heterogeneous or unknown selection category. And the other one is the patients who were treated according to the plasma levels of the DOACs. And third one is they have done the reversal of the dabigatran therapy with idarucimab. In the first group, we can see that the symptomatic ICH rates were about 3 to 4% across all these studies. And in this particular study, they have included patients less than 48 hours also. And some of the patients they have done partly plasma level based also in this study. And among the patients who underwent the IV thrombolysis after the DOAC, after measuring the levels of the DOAC, they have 3 studies. In the first study, they included 9 patients, and all of them were under 48 hours. Only 1 patient had symptomatic intracranial hemorrhage. And in the remaining 2 studies, there is no reported symptomatic intracranial hemorrhage. As I already showed some of the studies in patients who are receiving dabigatran, receiving reversal of idarucimab, the rates of symptomatic intracranial hemorrhage were about 3 to 4%, except in one study where they showed higher rates of symptomatic intracranial hemorrhage, because in those, most of the patients had elevated thrombin time. So based on these observational studies, the European Stroke Organization have made consensus statements. They could not come up with a strong recommendation because of the lack of evidence, both for the treatment patients on the direct oral anticoagulant, both on the factor Xa inhibitors as well as on the dabigatran therapy. And they have given the expert consensus statement that patients who are on the newer oral anticoagulants during the last 48 hours before the stroke onset, and patients have the anti-10A activity less than 0.5 or thrombin time less than 60 seconds for the direct thrombin inhibitors, they can be given IV thrombolysis with altiplase. And patients who are on dabigatran, they suggested after reversal with idarucimab, they can undergo IV thrombolysis. And for factor Xa inhibitors receiving patients, after reversal with endoxanate alpha, they can undergo IV thrombolysis. Coming to the other guidelines, the French Society of Vascular Neurology has given similar guideline, but here they have taken the DOAC levels of less than 50 nanogram per ml or reversal with the idarucimab in case of dabigatran. Where in other cases, they also looked at the anti-10A levels before giving the IV thrombolysis in these patients, and Australian guidelines were comparable with the French Society guidelines. Now coming to the proper article, this is the article is titled Intravenous Thrombolysis in Patients with Ischemic Stroke and Recent Ingestion of Direct Oral Anticoagulants. This was published in JAMA Neurology in January 2023. The aims of this current study are to look into the risk of the symptomatic intracranial hemorrhage in patients with recent ingestion of the DOACs receiving the thrombolysis for acute ischemic stroke compared to the controls. And they also looked into the relative safety of different selection strategies. The strategies that included were like the same ones which I told, that is that after measuring the levels of the DOACs, after reversal of the DOAC therapy with the approved agents, or patients knowingly receiving the thrombolysis without measuring the DOAC levels or without reversal. And the fourth small subcategory is that patients who received inadvertently IV thrombolysis without knowing that they are on DOAC therapy. And they hypothesized that the risk of the symptomatic intracranial hemorrhage is not higher in patients with recent ingestion than in ingestion of DOACs than in controls, irrespective of the selection strategy. That is the following, the above 4 strategies. So coming to the methodology, it is an investigator.
Mr. Mohan, it's primarily a safety study.
Yes, sir.
Not an efficacy study, right?
Yes, sir. It's an investigator-initiated study, it's a retrospective cohort study, and they included 64 centers across the globe, and they collected pooled individual patient data, both from published as well as unpublished cohorts, where they have taken data from the electronic medical records. And they have done a systematic search in the PubMed and Embase, and they included publications between up to the 31st July 2021 with keywords of concepts of ischemic stroke, DOAC therapy, and IVT. And they have identified centers with published studies on IVT with recent DOAC intake. And they have also included prospective IVT thrombolysis or all other stroke registries, which may have included patients with recent DOAC intake. And they have identified centers and invited them to participate. They've included 64 centers spanning across Europe, Asia, Australia, and New Zealand. And they've included consecutive patients treated between 2008 and 2021. The inclusion criteria are all the adults more than 18 years, including both the sexes, and patients receiving IV thrombolysis for acute ischemic stroke and confirmed ingestion of DOAC therapy less than 48 hours ago, who underwent IV thrombolysis either with altiplase or tenecteplase, irrespective of the dose. The doses were depending upon the local guidelines, and they did not even take the limit of the time window for the IV thrombolysis. The only exclusion criteria they have taken is patients with last known DOAC therapy more than 48 hours before the stroke onset. And they have compared these patients with control patients. And the control patients were patients who had acute ischemic stroke with IV thrombolysis with no prior oral anticoagulation, either DOAC therapy or the vitamin K antagonist. And they've included the patients from all of the above participating centers. Along with that, they have taken the data from the prospective thrombolysis in ischemic stroke patients risk collaboration data set. And they measured the.
So they were done at two. They were all done at the same time, or they were all.
No, sir. They have included patients from different time frames.
TRISP collaboration study data set was sometime.
Yes, sir. Not only the TRISP collaboration data set, also among the participating centers, the data set, they mentioned that the data set is of different time frames. Sir.
I think it's only chart reading. All the records have been studied and the outcome has been documented.
Yes,
A priori, there is no research element. There is not a prospective study. Okay, carry on.
No, I think it has got both prospective and prospective also there, no?
No, all the patients that included in this study are from the retrospective cohort data, sir.
Retrospective cohort, okay.
Yeah.
There are prospectively collected patients are also there. Yes, prospective patient data set is also there, but all are patients who have been not looked specifically into this. These are all registry data set which has been looked into.
The primary outcome looked into is symptomatic intracranial hemorrhage until 36 hours after IV thrombolysis with at least 4 points worsening in the NHS score. And the secondary outcomes looked were into any radiological intracranial hemorrhage, which including the symptomatic ICH, and the functional outcome, that is MRS score less than or equal to 2 at 90 days. And they have taken a predefined analysis plan to adjust for the known predictors of symptomatic intracranial hemorrhage, which includes the age, arterial hypertension, the baseline NHS score, the premorbid functional independence, and the admission blood pressure and the plasma glucose level. And they've done a multi-level mixed effects logistic regression analysis. And they have also included the geographic region as a random effect. And they have done, to compare the different selection strategies, they have used the selection strategy as a factor variable in the model itself. And they have done the sensitivity analysis for each of the specific one, like geographic location, availability of the standard institution operating procedure, or the plasma levels of the DOAC more than 100 nanogram per ml or proven ingestion within 12 hours before the IVT. And for the secondary outcomes, they have done multi-level mixed effects, logistic, and ordinal regression analysis with adjustment as mentioned above. Coming to the baseline characteristic differences, they have total 32,207 patients, out of which 832 patients received IV thrombolysis while on DOAC therapy. And they found out that the median age is statistically significantly, higher in the patients on DOAC therapy and receiving IV thrombolysis compared to the control group. It is statistically significant. There is no difference between the gender between both the groups, and the median NIH was also found to be higher in the patients on DOAC therapy, and but the admission systolic blood pressure and the admission blood glucose levels were not statistically significant between the two groups.
Krishna Mohan, the patients on oral anticoagulants.
Yes, sir.
Are they are more from Asia? The Asian countries, their percentage is higher. compared to the European countries.
So most of the countries are from the Europe, and from the New Zealand and Australia. Most of the centers are there, sir.
Any other parameters significantly different?
Yes, sir. Yes, sir.
Okay.
And coming to the antiplatelet therapy patients who are on antiplatelet therapy, they found that in the control group, the patients were more on the antiplatelet therapy, both the single antiplatelet as well as the dual antiplatelet. And they found out that among the risk factor profile, the smoking was higher in the control group, and the hypertension and other and diabetes and other risk factors are more in the patients on the DOAC therapy. And the number of patients who had atrial fibrillation was also more in the patients on the DOAC therapy. And the most common indication for the DOAC therapy in the was atrial fibrillation. And patients who had large vessel occlusion and who underwent mechanical thrombectomy were also more in the patients in the DOAC therapy group, and it is also statistically significant. And the time from symptom onset to thrombolysis, the median time is also more in the DOAC therapy group. And in the DOAC therapy group, they most likely received tenecteplase was given in the DOAC therapy group compared to the control group.
So this our study is not a randomized intervention or something. In randomized studies, generally, these differences will be very often negligent, and
Yes.
It's an observational analytical.
Yes.
Yes. Now, among the patients who are on DOAC therapy and either receiving IVT therapy or not receiving IV thrombolysis, this data was available from few of the centers, and they found out that the median age, the median NIHS score, the mean systolic, the median time from symptom onset to the hospital admission, and the mean blood glucose level were significantly higher in the patients who were not receiving IV therapy while on DOAC therapy. So there was a selection bias in including the patients who received the IV thrombolysis in the centers also. And also they found out that among these patients, the presence of large vessel occlusion and mechanical thrombectomy, the patients who underwent mechanical thrombectomy were more among the patients who are receiving the DOACs and also receiving the IV thrombolysis.
So that usually happens, no? Most of the time you tend to select patients who are less likely to bleed. So that is why the difference is there when the age is also lower in those patients and the NIHS. But NIHS is actually higher in that group, but age, no? Those factors were definitely more in the other group where we expect the bleed risk to be lower, to try to be on the safer side.
So you want to comment, Krishna Mohan, of all these various factors where you found some differences between the two groups? Which of them are theoretically could affect your primary outcome of symptomatic intracerebral hemorrhage?
Theoretically, the more the age and also higher the median NIHS score and higher the admission blood pressure and also the blood glucose levels, they determine the higher chance of the symptomatic intracerebral hemorrhage. And also patients who are already on antiplatelet therapy also indicates the also has higher rate of symptomatic intracerebral hemorrhage.
Yes, but are they all in one group, or they are in the different? They are also balancing out in the two groups.
No, so in these two groups, this data is available only for few of the patients who received. Among the 832 patients, only 348 patients this data is available. So only few centers have given the data comparing the patients receiving thrombolysis and no thrombolysis among the DOAC group. And in that they found out that they looked into that the median age was more in the patients who did not receive the IV thrombolysis, and also the median NIHS score, NIHS score was more in the patients who received IV thrombolysis. And here also we can see that the median time from symptom onset to hospital admission is more in the patient who did not receive the IV thrombolysis.
Yeah, so there is some kind of balancing out also. Okay.
These biases are likely to happen because these are retrospective study.
Yes.
It's an observation. It will happen.
And that too, you tend to treat them when they come early. We feel that the core may be smaller and you tend to treat them. That may also be one reason why median time from onset to hospital admission. That is also lower in the DOAC group who received IVT.
And a lot of these centers are very advanced stroke centers, isn't it? Many
Yes,
of them.
yes.
Yes.
Most of the centers are European centers. So
Yes, yes.
definitely they are all, and I think one center from New Zealand and few centers from Australia.
Australia.
Okay, continue. You can continue.
And the patients receiving IV thrombolysis while on DOAC therapy were divided into 3 groups depending upon the selection category. That is, after measuring the DOAC levels or after giving the reversal with idarucizumab in case of dabigatran therapy, or neither of them were done, either without the known levels or who did not receive the idarucizumab. And among these 3 groups, when they were compared, they found out that the median age.
But they need not be mutually exclusive, no? Because some of them who get this idarucizumab must have also undergone this plasma level measurements of DOAC. No? So,
No,
I
no,
think they were just trying to classify to see that whether they come in any one of the group where you are tending to give the patient the treatment according to the guidelines. So maybe that is how their selection strategy was done. And
so
at
if you
least
add
if a
more,
level
that's
is available.
actually more than the total number. So there is some overlap.
Yes,
So
they will
that-
definitely
that's
there will be an
expected.
overlap. They only wanted to see, I think,
Yes,
that
yes.
they whether they receive the reversal agent or when they have whether they had a plasma level done.
and they found out that the median age, the median NIHS score, and also the median time from the last injection and the median time from the median INR and the thrombin time and the DOAC levels, all of these were statistically significantly different among these 3 groups. But they did not find any significant difference in the symptomatic intracranial hemorrhage within these 3 groups. It was 3.1 in the 3.1% in the patients who they measured the plasma levels, 3.1% in the patients where neither the levels were measured nor the reversal was done, and 1.2% in the patients where the reversal was done. And when they have looked into the primary outcome, they had this data for all the 832 patients who received IV thrombolysis while on DOAC therapy. They had the primary outcome data, and in the control group, they had about 98.9% patients had this data, and they found out that the 4.1% of the patients in the control group and 2.5% patients in patients who received IV thrombolysis while on DOAC therapy group had symptomatic intracranial hemorrhage, and but there is no difference among these 3 selection strategies. They did not find any significant difference. Here, after the adjusted odds ratio was 0.57, that is a symptomatic intracranial hemorrhage while on DOAC therapy, the adjusted odds ratio was only 0.57, and this is statistically significant. But there is no statistically significant difference among the 3 selection categories. And when they have looked into the patient baseline characteristics according to the occurrence of symptomatic intracranial hemorrhage, whether they are on the DOAC therapy or not, as previously mentioned, the conventional risk factors, that is the median age, the median NIHS score, the admission blood pressure, and the admission blood glucose levels, also the median INR, all of these were statistically significantly higher in the patients who had the intracranial hemorrhage compared to the patients who did not have intracranial hemorrhage.
So these are the factors in which there was significant difference between the 2 groups, right? There must be other factors which are not significant. But
yes, sir. Like these factors were statistically significant between the groups who had hemorrhage and who did not have hemorrhage. When they looked into the data overall, like irrespective of if the patients had received a DOAC or not, when they looked into the data, these characteristics were statistically significant.
Gender had no difference.
And also the patients, like while on antiplatelet therapy, patients who underwent mechanical thrombectomy, vitamin K antagonists, and patients on the recent ingestion of the vitamin K antagonist, these all were statistically significant difference between these 2 groups. But when they looked into the baseline characteristics who had symptomatic intracranial hemorrhage while on DOAC therapy, the same characteristics that includes the age, the median NIHS score, the pre-stroke MRS score, the mean admission blood pressure, as well as the blood glucose level, they were not significantly different between these 2 groups. That is the patients who had hemorrhage while on DOAC therapy and received IV thrombolysis. So that may be that the bleeding in these patients is probably only because of the direct oral anticoagulant rather than these conventional risk factors. And also we can say that maybe the conventional risk factors may not be helpful in differentiating the patients who are receiving IV thrombolysis while on DOAC therapy. And coming to the pre-specified sensitivity analysis, they have done according to the geographic region, and they did not find any significant difference according to the different regions, or whether the center had a standard operating procedure, or whether the plasma levels of the DOAC were more than 100 or proven ingestion less than 12 hours. They did not find any statistically significant difference. And coming to secondary outcome, that is the patients having
What is
any
that
hemorrhagic transmission.
center who has standard protocol?
Sir?
There, it's showing some significance, no?
Yes, sir. It is p-value 0.03. Yes, sir.
But is it expected way, or is it a higher SICH or lesser SICH?
Sir, actually,
Lesser. It is
lesser.
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 0.4.
And when they have looked into the secondary outcomes, that is presence of any kind of hemorrhagic transformation, which includes the symptomatic ICH also. In the control group, it is 17.4%, and in the DOAC group, it is 18%. And when they have seen the adjusted odds ratio, it is 1.18, but it is not statistically significant. And looking into the functional independence, about 45% patients in the DOAC group and 57% patients in the 57% of the patients in the control group achieved this MRS less than or equal to 2 at 90 days, and the adjusted odds ratio was 1.13, which is not statistically significant. And they also did not find any
there was a
significant
difference, but after the adjustments, there is no significant difference for the functional outcome at 3 months.
Yes. They did not find any significant association of DOAC therapy with disability categories in the ordinal regression shift analysis, although the point estimate favored patients with recent ingestion of the DOACs. And they have also included whether the patient underwent mechanical thrombectomy to the model, and they found out that the odds ratio is 0.54, and that is these patients did not have significant increased symptomatic intracranial hemorrhage. They also included the large vessel occlusion, whether the patient had concomitant antiplatelet therapy to the model, and they found that all of these values, the odds ratio were less than 1, and these were the p-values were less than 0.05, and that is statistically significant difference. But when they looked into the duration of the DOAC last ingestion, whether it is less than 12 hours, 12 to 24 hours, or 24 to 48 hours, they did not find any statistically significant difference among the groups according to the duration less than 48 hours. And when they have taken the documented DOAC levels of more than 100 nanogram per ml or ingestion less than 12 hours also, they did not find any difference. The p-value is only 0.472 in this group. But when that is, these patients did not have significantly increased symptomatic intracranial hemorrhage, irrespective of the patients whether they had the DOAC levels of more than 100 or patients had large vessel occlusion, or the drug was taken less than 12 hours, 12 to 24 hours, or 24 to 48 hours.
That atrial fibrillation, there is a difference, no? Adding atrial fibrillation to the model.
Sorry, sir. Which one, sir?
Adding atrial fibrillation to the model, that confidence intervals are.
Yes, sir. Adding atrial fibrillation to the model, the odds ratio that the patient developing symptomatic intracranial hemorrhage was only 0.46. So this is significant. That means that even after adding the atrial fibrillation to the model, there is no increased risk of symptomatic intracranial hemorrhage in the patients receiving the DOAC therapy.
Yes.
What does that tell you? No, you can't read much into any of these things, but just broadly, what does it tell you?
So, like, though the patients had, like maybe the patients with atrial fibrillation, that means that patients having cardioembolic stroke in these patients, even these patients receiving IV thrombolysis while on DOAC therapy, still there is no increased symptomatic intracranial hemorrhage. Usually we expect these patients to have higher chance of hemorrhagic transformation actually.
These are all post-hoc sensitivity
Yes,
analysis. No,
yes,
we
yes.
cannot.
They did not find any difference regarding the association of the symptomatic intracranial hemorrhage with the factor 10A inhibitors, or whether the patient is taking the 2A inhibitors. And also among this, the control group, they have found the rate of the symptomatic intratracheal hemorrhage among patients taking the vitamin K antagonist with an INR of 1.7 or less was 5%. As I mentioned in the previous table, there is no difference between the groups when mechanical thrombectomy was added to the models for the dichotomized functional independence, and the odds of returning to the baseline MRS were similar between the two groups, and there is no association of the DOAC therapy with the death at 3 months. So this study is important because based on large retrospective observational studies only, the previous contraindications for IV thrombolysis were either eliminated or became less stringent, like example, the dual antiplatelet therapy, or patients who were previously on vitamin K antagonist treatment with INR less than 1.7. Now we are able to thrombolyze these patients also. So similarly, with this data, maybe we can take up the patients with DOAC therapy for the future for thrombolysis. So we already know that the symptomatic intratracheal hemorrhage was less in DOAC therapy compared to the vitamin K antagonist therapy, while they are receiving either for primary or secondary prophylaxis setting. And this is also the experimental data is also supporting the same. So therefore, the DOAC therapy may not be a true contraindication for IV thrombolysis. Coming to this study in specific, they have looked into the IV thrombolysis in DOAC intake less than 48 hours specifically, because all the guidelines are telling to we can thrombolyze patients who are taking DOAC therapy if they're taking the last dose more than 48 hours ago. And the symptomatic intratracheal hemorrhage is 2.5% in the DOAC group and 4.1% in the control group, which was statistically significantly lower in the group actually receiving the DOAC therapy, which we do not actually expect. So after adjustment, the DOACs were not associated with increased symptomatic intratracheal hemorrhage, irrespective of the selection strategy, whether they received the reversal of the agent, whether they have measured the drug level, or whether they have given the drug, IV thrombolysis without measuring the levels or giving the reversal. So the possible explanation for the reduced risk of the symptomatic intratracheal hemorrhage with recent ingestion of the DOAC compared to the controls may be because of selection bias, because as we have seen in the other group previously in the table, where patients who had received IV thrombolysis while on DOAC therapy and who did not receive the IV thrombolysis and DOAC therapy, there is mild some selection bias was present. So, however, in the current study, when they compared with the control group, they have found out that whether it is the older age, whether it is the higher median NIHS, or presence of whether they received the IV thrombolysis, the median time of receiving IV thrombolysis were all higher actually in the DOAC therapy group rather than the control group. So this does not support the assumption that there is a selection bias between the two groups. So there may be some other residual or unmeasured confounder because it is an unrandomized trial. So they also have mentioned some pathophysiological explanation for this finding. The preclinical experimental stroke models, they have all shown that there is no increased risk of ICH in the experimental animal models, where when they have given IV thrombolysis for the animal models already on the DOAC therapy. And also in the animal models, they found out that the thrombin inhibition is actually protective against the symptomatic intratracheal hemorrhage. So they postulated that the lower DOAC concentrations could potentiate the recanalization of the vessel occlusion, and the thrombin inhibition could minimize the disruption of the blood-brain barrier. The another explanation they have given is that the DOAC pretreatment might lead to smaller infarcts with lower risk of hemorrhagic transformation. So this trial, the ARTSS2 trial, done in 2007, published in 2017 in the Stroke Journal. Here they have given for the patients adjunct to ergatroban, which is also a direct thrombin inhibitor, along with the TPA, and they have given they have taken 3 groups. One is the control group, other one is the low dose group, and third one is the high dose group. They have given this drug for up to 48 hours following the IV thrombolysis, and there are total 90 patients in this group, and they found out that the rates of symptomatic intracerebral hemorrhage were similar among the control, low dose, and high dose arms. And in patients treated with the RTPA and adjunct to ergatroban, they found out there is no increased associated risk of symptomatic ICH, and provides evidence that it is actually more beneficial because they found out that the MRS score among these 3 groups, it's actually better in the patients who received the ergatroban compared to the control groups. Similar studies going on called as named as MOST trial. In this, actually 3 arms are present, where they're in one arm they're giving the direct thrombin inhibitor, and in another arm they're giving GP2B3A inhibitor, and third is the control group. They are giving these drugs following the IV thrombolysis. And coming to the second postulation, that is whether the prior DOAC intake will lead to the smaller infarct volumes, thereby a lesser chance of hemorrhagic transformation. This study published in 2018, they have looked into the data from 2011 to 2016, about 330 patients, among which 29 patients were on DOAC therapy. And they found out after the multivariate analysis, the treatment was independently and negatively associated with the proximal artery occlusion. And they have postulated that patients who are on DOAC therapy, they are associated with a smaller infarct volume and less risk of the greater proximal vessel occlusion. So coming to the strengths of the current study, it specifically addresses the patients taking DOAC therapy within 48 hours prior to the hospital admission. And in all of these patients, there is verified compliance and ingestion, so that they are sure that they have taken less than 48 hours. And the data was complete regarding the primary and secondary outcomes among all the patients. And there is no heterogeneity present according to the geographic region, even because they have done an analysis with the geographic region as the random effect. Coming to the limitations, as it is an observational cohort design, it is at risk of selection bias. So the patients with lower probability of symptomatic intratracheal hemorrhage, there is a bias towards giving IV thrombolysis among the patients receiving the DOAC therapy. Non-randomized trial.
Krishna Mohan, can I just interrupt you? Dr. Prasad, are you leaving, or you have any comments to make before your flight takes off?
I think he has left.
He has left already. All right. Okay.
He has written a comment which we'll read after the paper.
Yes, yes. I thought you might be able to just catch it. Yeah.
We'll
All right.
continue.
As it is a non-randomized trial, though most of the baseline characteristics were equally there's comparability between the groups. Maybe there's some unknown confounder in the group because it's a non-randomized trial, and the control population is a heterogeneous population, and it was generated partially in a different time frame and from some additional centers other than the participating centers. And the IV thrombolysis dose given was heterogeneous depending upon the local guidelines. And most of the patients received altiplase. Only 51 patients received tenecteplase among these 832 patients on DOAC therapy. And the baseline follow-up imaging modality used were not mentioned.
So the tenecteplase group alone, have they done any comparison between the two groups?
No, sir. There is no. They did not do any comparison between tenecteplase and the altiplase group.
No. I'm just asking the tenecteplase subgroup between the two groups which received a DOAC and
No.
Okay. Numbers are
Can go to the next.
So how to proceed forward? The prospective randomized clinical trials to definitively assess the safety of IVT are needed, and but it is unlikely that such a trial will take place. And also, even if a trial such takes place, there will be a strong inclusion bias, because whenever a patient comes to a center with direct the availability of mechanical thrombectomy while on the DOAC therapy, we usually prefer to take them to direct EVT rather than doing bridging. And also, to determine the predetermined upper limit of safety of the symptomatic intratracheal hemorrhage to include in the trials would also be challenging. So to conclude, in this study, they found insufficient evidence of excess harm associated with IV thrombolysis in selected patients with ischemic stroke with recent DOAC ingestion. And this is true regardless of the selection strategy, whether it is done after measuring the DOAC levels, it is done after reversal of the agent, or it is done without doing any of these two. And the overall benefit is likely consistent with because of the benefit of IV thrombolysis in these patients.
Thank you, Dr. Krishna Mohan. So that was a very good presentation. You have extensively gone through the paper in detail. So I would just like to put in a few comments. One is, let me just tell that what is the most important conclusions or the take-home messages for us from this article, because we know with the small series data and no non-availability of randomized controlled trials, these are the ways in which we can make our decisions in routine clinical practice. So that way, this paper is very important. For example, we tend to see patients. So one of the important information which has come out of this paper is that if you have a patient with an ischemic stroke, and if the patient is within 48 hours, still you are justified in treatment. It may not be an absolute contraindication. Probably it may become a relative contraindication with regard to the decision of treating these patients with IV thrombolysis. This is mostly because from the data which they have shown, they found that compared to the patients who have received DOAC and IVT versus the patients who were not on DOAC, that's a control group, in fact, the bleed risk was lower in the DOAC group. And second, even though they use the primary outcome as symptomatic intracerebral hemorrhage, if you look at the efficacy part, that from the outcome part also, they did not find a significant difference between that group. And one more important information from this paper is that even in the patients who are having the expected group who are likely to have a higher risk of bleed were there in the DOAC group, as has been seen by the higher age, having atrial fibrillation, being with a higher NIHS, all these factors whom we think are likely to have a higher bleed were there, and those patients also, there was no increased bleed. We do not know how much of reliability we can give for the post hoc analysis, because these are all data which is like, we will not be able to come to any conclusion. But the another important point I would stress is that this is a global trial. So this is not done in a very Asian population or Caucasian population. It's a mixed group of population where different countries and different study population is involved, which also gives value to the paper. So I think those are the important information. Probably without the availability of a randomized controlled trial, there is a option for even considering, because we do not have the factor 10A assay. So in those patients, still, if a patient is carefully selected, there may be a relative, the contraindication may become a relative contraindication, and you may still consider DOAC in selected situations with the available data. Thank you.
Mr. Mohan, where would you put the level of evidence from this alone? Of course, Dr. Shailaja has already told, and you also told how it's next to impossible to do a proper large randomized control trial and all to solve this kind of questions. But if we strictly put this particular study evidence, what will be the level of evidence from this study? No,
This study, though it is a, as already mentioned, it is a retrospective study. So here we have data from 2008 till 2021. The patients were included, and the patients were included across all many countries. And irrespective of the time, whether it is less than 12 hours, 12 to 24 hours, or more than 24 to 48 hours, they did not find a significant risk of intracranial hemorrhage following IV thrombolysis in these patients. So definitely this gives a good data, but compared
what
to
is the level of evidence? What Dr. Sunil is asking, with this data, where would you put your level of evidence? So is it class 1? So yes, so that is what
we have this class of recommendations and levels of evidence. 1, 2, 3.
This is a perfect example of class 4 evidence with high strength of recommendation. Because there is a difficulty in conducting randomized control trials. Though evidence is low, the strength of recommendation will be high in this case.
Yes.
Yeah, so something which we have to take from every trial, where we will place it. Suppose when you are forming guidelines, for example, you have to say what class of recommendation, level of evidence this can generate, but still we might it might still form important part of the guidelines, the given limitations which we already described.
Because large number of cases are required to see effect size which is significant in this type of study. So it is difficult to conduct that randomized control trial, and you require a lot of patients to show a difference. So I think this is the best we can have.
I just want to ask Dr. Shailaja again. In a suppose in a population of rheumatic valvular heart diseases, if you are putting them, do you think that would an exclusively RHD patients on suppose they are on DOAC, can we this would probably be same results we have to assume, isn't it?
Yes, I think it may, because anyway for the rheumatic we are unlikely to give the
Yes.
DOAC for these patients. Maybe in the select group of the mild MS where we may still consider DOAC, I think it does not depend upon the etiology, because they have patients with non-valvular AF and other indications also included in this data, which suggests that the etiology, they have not specifically looked at the etiology wise to look at the bleed risk, but I think it's mostly currently inherent to the DOAC compared to the other factors. So I think it may be relevant.
DOACs are not indicated or not recommended for rheumatic heart disease associated atrial fibrillation.
Yes,
strokes.
yes. It's only in the
And,
mild one. The latest recommendation showed that in the mild group, you may still consider.
Based on
But-
RELY trial, which has got 500 patients of rheumatic heart disease out of their 500,000 or 6,000 patients, a small subset is there. So
Yes.
And
that's
I
all
think countries like developing countries have to do such studies. We had some plans for ICMR to do such a study, but that didn't actually materialize.
Yes.
We don't know what
Yes.
is the current standard of Instruct network.
And is it so
Probably
prevalent
not in the
as it
near
was a
future.
couple of decades back? Rheumatic heart disease?
Oh, yes, sir. We tend to see lots because we are one of the centers doing a lot of valve
Tertiary
replacements.
care hospitals, yeah.
Even in JIPMER, we still get a very substantial number of.
We also get a lot of them.
In Pune, we are not getting many cases. Only one odd case will come.
No,
But not like when I was in
a
Osmania Medical College.
major health problem even now.
Maybe because ours is also center doing that surgery. That may be also one reason, sir. I think otherwise it may be definitely coming down.
I think the digital team, please open the forum for all others to join. Dr. Partha and others who are there, they may ask some questions.
Yes,
They can
yes,
participate in the discussion.
yes. Dr. Girish is here.
Dr. Girish from Nimhans is there.
Yes, sir.
Who
Yes,
is
sir.
going to present next month's Journal Club? Girish is tasked to do next month.
Dr. Partha.
Girish, Dr. Partha, comments or any questions or comments, please. I think since the discussion itself was very exhaustive.
Unable to access Lika,
Additional
Girish.
comments.
Girish, you can type.
Yeah. We have.
I think digital team, please
Can you-
unmute everybody.
And also they can bring in to the panel.
Yeah,
you
they
can
can
bring-
no, they can unmute and they can ask.
Yes.
Sir, I give rights to everyone.
Yeah. So that they
just
can
want to
participate in the discussion. Thanks.
Dr. Girish, are you around there?
He sent a
Girish has joined. Girish, you are muted.
Ma'am, and sir, good evening. I think it was a very nice discussion, sir. But my only one doubt we had, sir, like supposing we have a thought process that we will not give IVT in the DOAC patient if they have taken the drug within 48 hours. And we are going to give the drug only if we have the levels or we have a antidote. So then on what basis they have given without doing any of these two and then they have thrombolized the patient? That was the one thing. Now, if we have three groups and all three groups, there was no much difference in the bleed rates. So then on what basis this increased bleed will happen in patients taking DOACs was considered in the first place? That doubt also will come. So these are my thought process when we listen to this article.
So no, that is one question. Actually, Girish, what I understood from the paper is that they also did not have an answer why the data showed that the bleed risk was definitely lesser in the patients who have received DOAC and IVT. So for that reason, they have given those explanations. of one is that we also know that the patients who are already on anticoagulation, their strokes are likely to be lesser and the clots are likely to lyse better. So that is one reason they have given. And second is with regard to the thrombin, which Dr. Krishnamohan has already highlighted, where the blood-brain barrier disruption is not going to be affected, and this can also reduce the bleed risk. So these are the explanations, but otherwise, what I understood from the paper is they did not have a real explanation of this, but only this gives us some form of a comfort for in a select situation if you want to treat. But definitely, since it is not in the guideline. So as we know, for what I would take this paper is like initially, we all remember that when seizure at stroke onset was a relative contraindication when we were all doing thrombolysis initially. But now we never think of seizure at stroke onset as a contraindication at all.
Yes.
So I think it is an evolution and dual antiplatelets. We were very reluctant, or like we were a bit skeptical in giving IVT in patients with not single antiplatelet, we were not worried. But when they were on dual antiplatelets, we were a bit worried about giving. But now all those things have gone. So this is all from evidence we become more confident. So that way we could say that maybe in select situations, you may still consider giving the drug. There, most of the time, what we have found in our clinical scenario is they do not know whether the patient has taken the drug within 48 hours. So that is of the three groups. The second group is the one we usually may see. The patient may be aphasic, the relative doesn't know whether the patient has taken the drug or not. So in those situations, if you think that patient has come very early to you and you want to give the drug, there is some comfort that is excess harm is not done in these patients. So that is I think only the take-home message I felt, considering all the limitations of this paper.
I have one more related question. That is based upon the results of this study. Can we now, how confidently we can say that some of the earlier European guidelines where they were recommending doing thrombin times or DOAC estimations, can we completely do away with them? Because it's very difficult, only very few centers, hardly any center in India probably. And I don't know, Chitra does it, but as far as I am aware, no other centers does it. And even in foreign developed countries also, those who estimate DOAC levels or the thrombin times as a routine pre-thrombolysis facility will be very limited. So does this give sufficient confidence for us to do away with those earlier recommendations?
I think, Sunil, I think what you told is perfectly right. The only thing what I would say from this paper is that it at least improves our confidence in giving the IVT in these patients. Because I don't think before that, we never had any confidence. All the data were all small series and it is all with reversal agent and when the DOAC was given more than 48 hours. With this data, we can have some confidence, but unless it becomes a guideline, we may not be very confident in giving. But slowly it is likely to come up, just like the other contraindications became later indications.
It is becoming important. I remember we had actually only 2 weeks back, there was a patient whom we found out that patient had come in the window, but patient was on DOAC. We don't see too many patients on DOAC here in yes. Our institute. But they never gave a call at all to neurology because they thought that, oh, anyway, this patient will not be a candidate. So I think it's important to spread this message. Yes. Becoming more and more frequently being used. Thank you. I think if
before we wind up, just Dr. Saad's message we should read what he has in the chat box.
Oh, yes.
So what he said was that for interpreting the p-values, please look into the 95% confidence interval and the confidence limits and the width of the confidence interval to say whether to give importance or not. That's what is main essence in the paper. And it's a retrospective paper. So most of the questions, queries which we have raised, they'll go unanswered throughout and we have to take our own individual decisions. Nobody can recommend anything based on this paper. It's only your confidence level. If you want
Yes.
to take a risk, you should do it. And at no stage we can recommend this as a treatment for based on
Yes.
this. But it gives more confidence inadvertently. If you are given the medicine, you can hope for the best. So that the effect size is very small. So that's what I think.
There is a
one
question
more-
from Sharif Mira.
Yeah.
Can we thrombolize with the DOAC as I thrombolized with a Pixaban 24-hour back with post PTCA with earlier IV clot? He improved. Can we commonly? It's a little difficult to understand the question.
IVT, as his NIHS was 5 within the window, so I thrombolized. So this is an individual opinion. What do you say, Madam? Dr.
Yes.
Shailaja?
Yes,
Yes.
I think so. I think as you have rightly pointed out, Dr. Gothi sir, I think it's an individualized decision. As I also mentioned, this paper is not going to make you to give the thrombolysis for all patients who are on DOAC within 48 hours. But I would say in select situations, for example, like you feel that overall the risk is very low. For example, the overall IVT risk is low with a patient with a relatively good blood sugar, the blood pressure is not very high. So in those select situations, you have a more confidence in giving the drug because with this data, we feel that the bleed risk is not going to be that high. But unless it becomes a recommendation, I don't think we can routinely use it. But it's a good, that's what as Dr. Meera had shown, these are the situations you start treating and becomes a case series, and then later you become confident in treating these patients.
Yeah, you gain more confidence to give the medicine
Yes.
without a class 1 evidence.
Yes.
I think that Sunil, I think we had a good discussion. Shall we wind up now? It's time to wind up.
Yeah, I think
We thank profusely Dr. Shailaja, Dr. Krishnamohan, all the Sri Chitra team for their excellent presentation and discussions. And with final comments from Sunil Narayan, we'll wind up.
No, we already had the final comments.
Okay.
I think
Then
almost
I
all
think,
aspects.
Madam,
Thank
good
you.
night, and
Discussed.
good night, Dr. Krishnamohan.
Thank you.
You have done an excellent job. You studied
Thank you,
well.
sir. Good night.
But critical appraisal skills are to be learnt, and these are observational studies. Don't give so much importance and don't get carried away with
Yes.
these results. They are there to help. But unless you have a therapeutic intervention requires randomized control trials, as Madam has been saying, it's very difficult to conduct randomized control trial in this scenario. But I think with this, thank you
Yeah,
very
we'll
much.
just also invite everybody to join for the Journal Club next month. That will be probably again
Enhance.
Friday. Dr. Girish's team from NIMANS will be presenting a paper. Look forward to that and invite all of you to join that.
Thank
Good
you.
night,
Thank you,
everybody.
Dr. Sunil. Thank you,
Thank
Dr.
you, sir.
Gothi.
Thank you, ma'am. Thank you very much.
Thank you.
Good night.
Thank you, Krishnamohan.
Thank you, madam. Thank you, sir.